So I'm Annalee Coakley. I'm one of the family physicians at the Mosaic Refugee Health Clinic in Calgary. I'm very happy to be here today. I love being with my peeps, like-minded people, except it fills me with a bit of, I've got sort of a combination of both rage and hope inside of me. Rage at the rights violations and the barriers that our refugees face when they're resettling in Canada and elsewhere, but also hope because people like you are interested in helping them overcome those barriers and advocating for their rights. Which, back forward. Oh, sorry, I've messed it up. That's the button I'm not supposed to.
That's the button you're not supposed to push.
I need bifocals, sorry.
Just the top one there.
Okay, thank you. So anyway, I have there's no conflict of interest. There's not money in the refugee biz. And so today I was tasked with just reviewing the Mosaic Refugee Health Clinic model and some common resettlement issues that impact the health of refugees in Canada. I think a lot of the resettlement issues and barriers have actually been talked about, so I'll just focus on two of the most prominent ones from my point of view. And so again, this is the slide that we've seen before. Refugee clinics have sprouted up all across Canada, and it sprouted across Canada because there was a need that was identified. So the needs of refugees were not being met, and so in all of these refugee receiving communities, people got together to try to address their needs and fill the gaps in our mainstream health system. And I certainly wish there wasn't a need, and I completely agree with Dr. Andrea Hunter when she said, you know, she would hope that we wouldn't have the need for refugee health clinics in the future. And that's in fact my big, hairy, audacious goal. I want to work myself out of a job. I want our mainstream system to be able to address the needs of all of our refugees. And I feel like refugees are a bit like the canary in the coal mine. You know, and if we design a system that's responsive to their needs, it will help all of our citizens and all of our vulnerable populations. I'm from Alberta, so I get the question a lot in Alberta, why do we need a specialized refugee health clinic? Why do refugees get this gold-plated health care? And so, of course, I have to explain the concept of equity, and then I get into the nitty-gritty about why is a refugee different and why do they have different health needs than an immigrant? And so I think Christina Greenaway did a great job sort of going through the refugees' journey, right? Their pre-migration journey. So refugees are fleeing their home country for reasons of persecution. They've often had to make a treacherous journey to a safe host country. Mita, you know, his journey, days through the jungle. That journey is treacherous and it puts them at risk of different illnesses, infectious disease commonly, or trauma or sexual violence. They then arrive in a host country. They might be safe from the persecution, but they're certainly put at risk of various illnesses due to their conditions in that host country. So often they're living in crowded conditions, substandard housing, putting them at risk of different infectious diseases. They often don't have access to clean water and sanitation. Their educational opportunities have been disrupted. They don't have opportunities for employment or skills training. They certainly never plan to come to Canada, so they often don't know English when they first come to Canada. So their life's journey has put them at risk of infectious disease, of neglected chronic disease, undiagnosed, unmanaged genetic and congenital diseases like PKU. And of course, there's severe trauma can often lead to manifestations with poor mental health, PTSD, complex PTSD, somatic disorder, etc. And so they come with a high burden of illness. but they also face many barriers when trying to access care. So because they've not planned on coming to Canada, they haven't learned English, they haven't had sort of a good educational experience. Their English language proficiency tends to be lower. Their health literacy tends to be lower. Because they don't have skills and they don't speak the language, they're often stuck in poverty and working at survival jobs when they come to Canada. They often have lived in rural environments, and so coming to Calgary, they're overwhelmed with our public transit system. They are unsure how to navigate either the health system or social system or just the city itself. And so when you're assessing a patient with multiple needs, that takes time. When you're working through language and cultural barriers, that takes time. When you're trying to explain to patients how to get from point A to point B, that takes time. When you're trying to educate them about their diabetes, that through an interpreter and through the low health literacy, all of that takes time. And as mentioned by somebody earlier, doctors are generally paid fee for service. So in my city, they're paid, family doctors will book patients every 5, 10, 15 minutes at the max. And so really, 10, 15 minutes is really inadequate to address the issues and meet the needs of the patients. And so our clinic is the Mosaic Refugee Health Clinic, and it was founded in 2003 by a community medicine resident. So the resident noticed that the Sudanese refugees were accessing the emergency department quite frequently in order to address a lot of their health needs, which could have been served in the community had they been able to access services in the community. And so what he started to do is he went into the Resettlement Center where all of our government-sponsored refugees spend their first 3 weeks. And he started a clinic 1 day a week, assessing patients, meeting their acute needs, identifying chronic disease, doing screening tests, et cetera. And just over time, that clinic grew. And so with 2013, so it grew and grew and grew, where we were then busting at the seams. And then in 2013, Calgary was flooded. And in the flood, the clinic was destroyed because we were right next to the river. And so, there's blessings. There's always a silver lining. And so the silver lining was one of our primary care networks who had a surplus at the time, and so it was very serendipitous. They agreed to adopt us. So they adopted us, they put us up in swanky new clinical space. And then because they are part of the larger mainstream system and they were very well resourced with the surplus, and that'll never happen in another 100 years, but they were able to expand our services. And so currently, as it stands, we have 17 rotating family physicians. The family physicians are paid an hourly rate, so we have adequate time to see patients. They all have additional training in tropical medicine. Really, we're a core of 8 family docs, and then we have the remainder are locums. We have a very large multidisciplinary team, and the reason we need such a large team is because the needs are quite large in those first year or two. And so just in terms of our multidisciplinary team, we have 3 social workers, 2 psychologists. We have nurses who really act as complex case managers. Okay. And a health navigator, a medical office assistants because patients are unable to speak the language, book labs, book diagnostic imaging themselves. We have public health nurses that come to the clinic and vaccinate our patients, and we have a transition coordinator. So we have a program very similar to the Halifax program where we have somebody dedicated full-time in attaching our patients to clinics. And we bring in the specialists. So to overcome some of those barriers to navigation, we have a whole roster of visiting specialists, and we work very closely with our community partner, the Resettlement Agency, which is CCIS in Calgary, and we have 2 nurses that are embedded into the resettlement center to triage refugees as they first arrive. So it's an embarrassment of riches, really, if I look back at where we've come from. And so our whole goal is to manage their acute issues, stabilize chronic disease, complete the screening, address mental health issues as they arise over their next 2 years, and engage patients into preventative healthcare and teach patients how to be independent navigators of the health system before transitioning them to their permanent medical home. I'll just go through that. So just in terms of the resettlement issues, I mean, there's so many resettlement issues, but the one that I come across time and time again is language and health navigation. So Dr. Gruner mentioned the health navigator. It's essential to have somebody who is mobile, who speaks their language, who's able to teach people how to navigate the city and to take them to various health appointments or link them to community agencies. And the language barrier is a huge issue for us. And so I feel like we need to start thinking outside the box a little bit, and maybe it shouldn't be the responsibility of the health provider to provide the interpreter, but maybe we give the patient some sort of access on their phone, because they all have phones, where when they're dealing with somebody, maybe until they get to level 4 ESL, they have an account, hopefully funded by the federal government, where they they can access interpretation that way. But I think this is where your brains are essential in helping us overcome the language and navigation barriers. And so in conclusion, refugees arrive with health needs and barriers in accessing health care, and that's why we need a specialized clinic. And in order to meet the health needs, we need to overcome those barriers, and that's where research plays a key role in identifying, proposing solutions, and evaluating programs that help refugees overcome those barriers. Thank you.